Dementia, and I stress on dementia to be treated in these patients because it's the main feature of this condition. By cholinesterase inhibitors, rivastigmine and donepezil, and this has got a class 1 evidence efficacy in DLB. DLB often greater treatment response than Alzheimer's disease due to profound cholinergic deficit. What about psychosis? As I said, avoid DA blocking antipsychotics. And the non-pharmacological is similar to the other conditions and similar to Parkinson's disease with home modification and coping strategies as well, excluding the underlying medical illnesses in terms of infection and so on, discontinuing exacerbating medications such as painkillers that may subject the patient to developing psychotic side effects. CNS medications as well, reduce or discontinue any Parkinson medication if psychosis develop or reduce them as much as you can. Pharmacological agents include antipsychotics in the form of quetiapine or clozapine. Pimavanserin has also been tried. Now, this is another agent that has been tried in Lewy body dementia. It's called mebudamin. And this is a selective positive allosteric modulator of the dopamine D1 receptor subtype. This study was conducted over 12 weeks, a phase 2 randomized placebo-controlled trial, looking at a primary endpoint to assess the safety and efficacy on cognition, and also to look at the Unified Parkinson's Disease Rating Scale. However, this medication failed to meet both the primary and the secondary endpoints, especially on cognition. I'll move on now to progressive supranuclear pulsing. I've just put on this figure where you can see the round of house sign as illustrated for a downward saccade in patients with progressive supranuclear palsy. So to diagnose progressive supranuclear palsy syndromes, it's important that we remember the different types of PSP. We have the classic type, which is the Richardson syndrome, and that is characterized by early gait instability, dysarthria, dysphagia, axial rigidity as well, and frequent falls. Then there is the other type, which is the PSP Parkinsonism, and this is, in addition to the previous features, there's tremor, additionally, and late cognitive decline with a longer life expectancy. The PSP pure akinesia with gait freezing mainly involves gait difficulty and freezing, especially with some motor blocks on walking. It can present also like similar to Parkinsonism with micrographia as well. There's speech impairment, hypophonia, and it has a longer disease duration. The PSP corticobasal syndrome, which is similar to the corticobasal syndrome that I'll speak about later on, involves dystonia, dyspraxia, corticosensory loss, and apraxia of speech as well. And there is the behavioral variant of frontotemporal dementia, PSP type, which is predominantly affecting the cognitive function, personality changes. However, it presents later on with Parkinsonism. Then we've got the cerebellar type that presents mainly with cerebellar ataxia with some element of Parkinsonism, and definitely dementia. As I said, this is a main feature. And the lateral sclerosis type of PSP, which involves bulbar symptoms in addition to the previous ones mentioned. So in terms of treatment, again, it's mainly symptomatic, treating the motor symptoms with dopaminergic agents, dystonia with botulinum toxin injection, speech and swallowing with the Lehman-Silverman techniques, orthostatic hypotension with salt, hydrocortisone, midodrine, droxidopa, solifenacine, neurogenic bladder, and antidepressants for mood, cholinesterase inhibitors and stimulants for apathy, and cholinesterase inhibitors again in MMT for cognition as well, and treating the gastroparesis. So it is similar to the other conditions of atypical Parkinsonism as well as Parkinson's disease. So the treatment is similar to what I've just mentioned. However, the agents are levodopa, amantadine, amitriptyline, zolpidem, coenzyme Q10, which I'll speak about later on, showed some mild improvement in motor and neuropsychological symptoms, and botulinum toxin obviously is very good for focal dystonia, especially those patients who've got blepharospasm or retropolis or antropolis, then botulinum toxin can be very beneficial. These are some of the trials that have been looked at, and I've just put in black on top of the table here. You can see the agents that I've tried and resulted in negative results include riluzole, lithium, and tidabucid, and davunatide as well in a phase 2 to 3 microtubular stabilizer, anti-tau antibody as well. And these agents have all been tried in patients with Parkinson's, with PSP, in corticobasal degeneration as well, alongside with Alzheimer's disease and frontotemporal degeneration, behavior variant as well. However, none of them gave good results. Moving on to the third type, the corticobasal degeneration. And again, there are proposed criteria for the clinical phenotypes of this condition associated with the pathology of the corticobasal degeneration. And it's important to remember the different types. For example, the probable corticobasal syndrome is an asymmetric presentation of two things: limb rigidity or akinesia and limb dystonia, as well as limb myoclonus plus or orobuccal limb apraxia, cortical sensory deficits as well, and alien limb phenomena, which is a characteristic feature of corticobasal degeneration. Other types is the possible corticobasal, maybe asymmetric one, of a limb rigidity or akinesia or dystonia or alien limb phenomena, just as we mentioned in the previous one. The frontobehavioral type includes executive dysfunction and behavioral personality changes and visuospatial deficits as well. The non-fluent, fluent, or agrammatic variant of the primary progressive aphasia, mainly from the name, includes agrammatic speech, plus at least one of the following: the impaired grammar sentence comprehension with relatively preserved single-word comprehension, distorted speech production, for example, apraxia of speech, is the characteristic of this variant. The fifth one is the progressive supranuclear palsy syndrome, and it includes axial or symmetric limb rigidity, akinesia, postural instability, in addition to urinary incontinence, and obviously the characteristic of PSP from its name, supranuclear vertical gaze palsy or decreased velocity of vertical saccades. And these are one of the features that are picked up when you diagnose a patient with PSP, the loss of the gaze movements upwards and downwards. So the diagnostic criteria for corticobasal degeneration, normally you would have in a probable sporadic CVD, you would have an insidious onset with gradual progression. The age of onset is 50 and above, with possibly family history of 2 or more relatives. However, this is not necessary. And then you've excluded a genetic mutation in this condition as an alternative diagnosis. The clinical criteria for possible CVD is an insidious onset and gradual progression, and also there's no minimum age for it. However, normally it is at the age of 50. Again, symptomatic treatment, such as similar to what I've mentioned previously, and it's no different medication than the others, including the levodopa, botulinum toxin, baclofen, clonazepam, propranolol, depending on what the features are or the clinical presentation. These are some of the disease-modifying treatments for categorized atypical Parkinsonian syndromes, and we've categorized them here into 2 types: the tauopathies, which is the corticobasal syndrome, and the progressive supranuclear palsy. And in this group of medication, you can see those that affect the tau dysfunction and those that look at the mitochondrial dysfunction. Other strategies have also been tried, such as riluzole. And you can see here that riluzole has been tried in so many conditions. Yesterday we spoke about riluzole being tried in hereditary ataxias as well. In terms of tau dysfunction, there are some medications that I've mentioned earlier on, like davunatide, which was found to be non-effective in this condition, and others that looked at coenzyme Q10, working on mitochondrial function, and that also didn't reveal much of a benefit except on at a limited level. There are some ongoing pharmacotherapies in tauopathies, which is CVD and PSP, such as the microtubule stabilizer, TP1287, and stem cell treatment, as well as other ASOs and BMS. Synucleinopathies, we talk here about DLB and MSA mainly, and the medication tried here include rifampicin and kallikrein as well. Intravenous immunoglobulin has also been tried. Again, riluzole has been tried as an antiglutamate drug in these patients. Antidepressant, fluoxetine, which I've mentioned earlier. Immunomodulatory drugs have been tried. Other antioxidants like curcumin has also been tried in the management of synucleinopathies, but none of these medications revealed significant change in function. These are some of the trials that have been conducted on some of the medication that I've listed earlier on. And you can see here the rotigotine have been tried in almost all of these conditions, MSA, PSP, CVD, and LBD, over 24 months as transdermal patches. But there was some significant reduction on the Unified Parkinson's Disease Rating Scale, motor section, but not very significant. Others that yielded a little bit of significance was the mild improvement using the coenzyme Q10 as a liquid form. However, others such as rifampicin and razogeline did not yield any effect. Others here, I've mentioned already that razogeline did not result in any effect on the primary and secondary outcomes in PSP patients, and there's a little bit of improvement with donepezil and rivastigmine, especially on LBD. We've already talked about this, the daducolucid. That didn't reveal any changes from baseline, especially in PSP patients. And memantine was tested in Lewy body disease in terms of dementia, and that revealed only mild improvement in the cognitive scale. This we've already spoken about, the davunitide, and that was used intranasally in patients with PSP at a dose of 60 milligrams per day, and that also did not change the features from baseline. There are some clinical trials for the treatment of atypical Parkinson's, as you can see here in this table, and these are some of these that are ongoing, some of that has been completed. However, although some of them did show some change in function, especially on cognitive function, very minimal though effect. Some of them have been safely and tolerable, especially in terms of adverse events, but none of them revealed significant change in the motor scale or the cognitive scale as needed. This is a nice paper that I've actually looked at, looking at my talk and preparing for it, and I've just listed it here for you that you can see that these are most of the novel therapies for Parkinsonian syndrome that I've spoken about are available and in nice tables and a nice illustration in this review article. So what did these new agents or the studies look at? Well, mainly the anti-Parkinsonian therapies have looked at effect on phosphorylation or aggregation inhibitors. They've looked at mitochondrial targeted therapy, also looking onto subduing neuroinflammation, looking at proteasal activation, targeting microtubules as well. They've also looked at changes through immunologic response via antibodies or stem cell therapy as well, especially in PSP and MSA. And however, some of these are still ongoing trials looking at all of these agents for good effects in the management of patients with atypical Parkinsonism. So the symptomatic management, mainly, as I've mentioned, in all these conditions, are mainly to tackle Parkinsonism by levodopa, dystonia, probably by some agents like botulinum toxin or clonazepam, treating myoclonus, gait and balance impairment, tackling speech and swallowing disturbances with gastrostomy tubes or with training. Dysautonomia symptoms can be tackled by treating the orthostatic hypotension and the urinary incontinence and bladder problems, erectile dysfunction as well. Pseudobulbar effect can be also managed in ways of management through occupational therapy or speech therapy, tackling also swallowing problems, and mood and behavior symptoms as well can be treated as well, similar to the previous treatment that is used in other conditions of atypical Parkinson and Parkinson's disease as well. So in conclusion, presently the disease-modifying strategies for atypical Parkinsonian syndromes are being actively explored with encouraging preliminary results, and we assume that developing an accurate, safe, and progression-halting treatment is not far off, but it is coming. There are a few positive phase 2 trials evaluating novel therapies that I've just listed in the previous slides for dementia with Lewy bodies and MSA, but overall the clinical trial in atypical Parkinsonism haven't delivered positive results as of yet. Nevertheless, the further investigation still remains necessary. The role of non-pharmacological treatments in the development of novel targets are two emerging topics in the field of atypical Parkinsonism that could influence future clinical trials. So are we there yet? I'm afraid we're not there yet. We're still walking slowly towards getting a treatment and finding a novel treatment for the management of Parkinsonism or atypical Parkinsonian syndromes. There are lots of trials ongoing. However, that one medication that treats these symptoms is not there yet. Thank you.
Thank you. Thank you. Is she still there? Thank you, Zakia. Are you still there?
I'm still there, yes.
Okay.
Was there a question?
No. No, just wanted to say thank you very much for your talk.
Thank you. It's my pleasure. Thank you. Thank you for inviting me, and it's been a pleasure presenting these talks.
Okay, have a nice day. Take care of yourself.
Thank you very much. Thank you. Bye-bye.
Bye. Okay, colleagues, we are trying to catch up on time today, so I hear the lunch is already there waiting for you, so we need to do that and come back, and once we come back, Isaki, you're coming on board, and Serge. Where is Serge? Oh, okay, he's there. So after lunch, two of you are coming on board. After stomach stimulation. Okay, guys.